For our recently published paper in eClinical Medicine, we asked an important question. Could venous obstruction in the pelvis contribute to orthostatic symptoms in patients with POTS? In clinic, we had repeatedly noticed that many patients diagnosed with POTS were also reporting pelvic pain, urinary symptoms, leg swelling, and lower back pain. Pelvic venous disorders, particularly iliac vein compression, can cause blood pooling in the lower body and impaired venous return to the heart. So we wanted to better understand the overlap. To explore this, we conducted 2 separate retrospective studies examining both the prevalence of pelvic venous disorders in POTS patients and what happens to symptoms when vein compressions are treated. In our first study at Emory, we evaluated patients referred for POTS or orthostatic intolerance. We screened 287 adults, of which 154 consented to participate, and 129 of those ended up completing a full pelvic venous imaging workup. The average age of our patients was 36 years old, and about 84% were cis female, which reflects the known female predominance in POTS. About 2/3 of our patients had a formal diagnosis of POTS, and the rest had POTS-like orthostatic intolerance syndromes. When we analyzed their imaging, we found that 83% had evidence of pelvic venous disorders. These included iliac vein compression, renal vein compression, or patterns of pelvic venous congestion. We also evaluated how well different imaging modalities detected these findings. Ultrasound identified about 53% of the confirmed cases. CT detected around 50%. MRI performed better at around 72%, but venography with intravascular ultrasound confirmed 99% of the cases. So taken together, this suggests that pelvic venous disorders may be under-recognized in POTS patients when you rely solely on non-invasive imaging. In our second study, we examined 271 women with both POTS or orthostatic intolerance and significant left iliac vein compression confirmed by intravascular ultrasound. All of our patients underwent iliac vein stenting, and we assessed symptom outcomes before the procedure, at 3 months, and at 12 months. We observed statistically significant improvements in orthostatic symptoms using the Orthostatic Hypotension Questionnaire. At 3 months, 68% of our patients achieved clinically meaningful improvement. By 12 months, that increased to 71%. Notably, 44% of our patients had symptom scores that fell below the threshold typically associated with active orthostatic disease, which means that remission level improvement occurred in a substantial subset. We also saw significant reductions in pelvic pain and urinary symptoms. And overall, 78% of our patients reported global symptom improvement following stenting. So our studies suggest that there is a strong association between pelvic venous disorders and orthostatic symptoms in some patients with POTS. And it suggests that venous outflow obstruction may contribute to excessive lower body pooling, reduced central blood return, and compensatory tachycardia upon standing. Importantly, when that obstruction was treated, many patients experienced sustained improvement in both orthostatic and pelvic symptoms. And for a condition considered chronic and difficult to treat, identifying a potentially modifiable structural contributor could have significant implications, but further prospective and randomized studies are needed. Ultimately, though, our findings encourage clinicians to consider whether pelvic venous disorders may be playing a role in select patients with persistent orthostatic symptoms.